Good afternoon, everyone. We'll start in just a couple of minutes. I'm just going to give people a few minutes to join. Okay, we'll go ahead and get started. My name is Jolene Riney. I am Manager of Quality and Payment Programs at Contexture. Today we're going to talk about the Medicaid Alternative Payment Model Program Year 2024, and we're going to focus on eCQM reporting for Program Year 2024. If you have any questions as I go, feel free to put them in the chat or in the Q&A box, and we will address those at the end. So today we are going to talk about Contexture's partnership with the Colorado Department of Healthcare Policy and Financing, or HCPF. We'll review roles and responsibilities, discuss electronic clinical quality measures to help practices be successful in the Health First Colorado alternative payment model, and I'll outline how practices can work with Contexture. Contexture is supported by the Colorado Department of Healthcare Policy and Financing as part of an overall initiative funded by CMS, which allows Contexture to provide no-cost support for PCMPs who wish to connect to Contexture. Costs are typically covered for practices reporting electronic clinical quality measures, or eCQMs, through Contexture, and Contexture is able to provide support and technical resources to minimize administrative burden on practices. Contexture's quality improvement team partners closely with the RAISE to provide support for the alternative payment model. For the APM program, practices select 10 total measures, which are a combination of structural, administrative, and eCQMs. The RAISE are responsible for structural measure support and assistance with administrative or claims measures, and Contexture's quality improvement team is responsible for supporting eCQM reporting. Structural measures focus on capacity and system processes and include things like alternative encounter types, patient satisfaction, and behavioral health integration. Administrative measures were formerly known as claims measures, and these measures are calculated from claims data that is submitted for Health First Colorado members. So examples of administrative measures include child and adolescent well-care visits. eCQMs are measures that are calculated directly from a practice's EHR or CCD data sent to Contexture from the EHR vendor, and they reflect health services or interventions being provided. In order for data to be reportable, it does have to be documented in structured data fields. Free texting will not meet those measure requirements for eCQMs. eCQMs do include the entire patient population for the practice, so any patient that was seen in the practice for a qualifying encounter and meets the measure criteria. Examples of eCQMs include diabetes, hemoglobin A1C poor control, or controlling high blood pressure. It is important to note that HCPF does require PCMPs to report additional eCQM data specific to their Health First Colorado patient population. So this means that when it's time to report eCQM data, practices will report two sets of data, their entire patient population and their Health First Colorado patient population for each eCQM selected. Some EHR vendors do not have the capability to report eCQM data by payer, but Contexture is able to assist with reporting both sets of data for these practices that connect to us to send CCDs. Scoring for the APM program in 2024 is based on eCQM data for the entire patient population. Practices that elect to send us their CCDs or continuity of care documents to Contexture can utilize the electronic reporting solution, meaning Contexture's quality improvement team utilizes the CCDs to extract eCQM data, validate the eCQM data, and work with the practice and their EHR vendor to improve the accuracy of the data. Practices who choose not to connect to Contexture or cannot connect due to EHR vendor limitations will be identified as manual reporters. And this means that when it's time to submit the data to HCPF, the practice is responsible for providing data to Contexture for each of their eCQMs. Manual reporters do not receive the same level of support from the quality improvement team as electronic reporters. So for our electronic reporters, data validation is completed for each practice and each measure that the practice has selected to ensure the accuracy of the data, and we do follow strict adherence to the measure value set. Data is validated for data completeness, inclusiveness in the CCD, and correct codes to meet measure specifications. So in this example you're seeing here, the screenshot shows in the lower right corner an eligible encounter with a CPT code of 99214, a diagnosis of hypertension, which places the patient in the denominator for the controlling high blood pressure measure, and then a blood pressure value below 140/90, which also places the patient in the numerator. Utilizing the electronic reporting solution by sending CCDs to Contexture and reporting electronic data does allow practices to receive technical assistance from the quality improvement team. The QI team will also provide quarterly reports to show performance trends and quarterly care gap reports, which can be useful for practices that would like to do patient recalls to get those patients back in to be seen. Electronic reporting ensures that practices are adhering to the measure guidelines and really decreases the administrative burden on the practice. So as far as timelines, practices should connect to Contexture as soon as possible. This just ensures that we have time to validate the data and work with you throughout the program year to improve that data. The timeline to report for program year 2024 is between January and March of 2025. But that 2023 baseline data can be reported at any time in calendar year 2024. And that baseline data becomes really important when we talk about scoring and points for these eCQMs. So a PCMP is eligible to receive the full point value for an eCQM if they report baseline 2023 and program year 2024 data with at least 20 patients in the denominator for both years and demonstrate close the gap or at least 10% improvement from baseline year to program year data. The other way that a practice can achieve full points is if they meet the goal that is set forth by HCPF for each measure. PCMPs can earn between 50% and the full point value for an eCQM if they report baseline and program year data and demonstrate close the gap improvement between 5 and 10%. PCMPs can earn 50% of the maximum possible points for an eCQM as long as there is at least one patient in the denominator, regardless of the performance rate. If a PCMP has a denominator size of 0, they will earn 0 points for an eCQM. When selecting measures for program year 2024, it's important to understand the measure definitions for each of the eCQMs, and we'll review those measure definitions in more detail later on. Research which measures are available to you through electronic reporting or through your EHR vendor. If you work on other quality programs, it can be beneficial to align measure selections with these other programs just to try to decrease some of that burden. If the measures are not available through a report in your EHR or through electronic reporting, it's important to understand how you're going to need to pull that data. It's also helpful to understand your current performance if you have measure data available in your EHR or through Contexture if you're already connected to us. When considering which eCQMs you're going to select, are you able to improve on your performance? And is this measure an area that you really wish to focus on improving in 2024? There are 3 mandatory measures in the pediatric and adult core measure set. So the table on this slide shows the pediatric mandatory measure set, which includes immunizations, well visits, and screening for depression. Additionally, the roll-in measure options listed here can replace any of the mandatory measures if you're unable to report on one of the mandatory options. This table shows the adult mandatory measure set, which includes screening for depression and follow-up, diabetes, hemoglobin A1C poor control, and controlling high blood pressure as eCQMs, or asthma medication ratio or screening for depression as administrative measures. Again, there are roll-in measure options listed to replace any of these mandatory measures if needed. So talking through some of these specific eCQMs available for you to select, we'll start with depression screening and follow-up. This is one of the mandatory measures for both pediatrics and adults. This measure is looking at the percentage of patients 12 and older screened for depression on the date of the encounter or 14 days prior to the encounter. Positive or negative value needs to be delineated and documented in a discrete data field for this measure. Positive value and negative value each have separate codes that identify the screening outcome, and that is required to meet the measure specifications. Additionally, if a patient screens positive, a follow-up plan also needs to be documented in a discrete data field using proper codes contained within the value set for this measure. Follow-up can be returning to the practice if symptoms worsen, provider in-house counseling or education, referral out to counseling, or prescribing a medication. It should be noted that patients with an active diagnosis of bipolar disorder will be excluded from this measure. A diagnosis of depression is no longer an exclusion for this measure, and this is a change from last program year. Contexture adheres to the value sets that are set forth by the Value Set Authority Center. Each eCQM that we talk through has specific data elements and codes that are required to meet the measure. So free texting for any of these eCQMs within a progress note does not meet the measure criteria. BMI screening and follow-up is the next measure we'll talk through. It is important to note the definition of this measure. We often hear practices indicate that they do BMI on all of their patients, and while that is often the case at preventative care or wellness visits, BMI isn't always documented at acute care or sick visits. So if that patient does not return during the measurement period for a preventative care visit, this could be a missed opportunity. Additionally, for this measure, if the BMI is outside of normal parameters, a follow-up plan should be documented using proper codes contained within the measure value set. This follow-up plan needs to be linked to a reason, such as overweight or obese or underweight. Again, free texting does not meet measure criteria. For the purposes of this measure, normal BMI range is defined as greater than or equal to 18.5 and less than 25. And follow-up could include weight management medication, patient education related to nutrition or physical activity counseling, or referral to a specialist. But again, the reason has to be linked to a diagnosis of overweight, obese, or underweight. The next measure is childhood immunizations, and this measure is specifically looking at children who turn 2 years of age during the measurement period and who had recommended vaccinations completed by their second birthday. With this measure, it's really important to note that historical vaccines received at another office or birth hepatitis B vaccines administered in the hospital should be reconciled within your EHR system, utilizing the correct CVX codes for the vaccine. Most unspecified CVX codes will not count towards meeting this metric. Patients who receive the recommended vaccines after their second birthday are not considered compliant with this measure. Immunization reconciliation is really a key piece to being successful with this measure for those patients that have received vaccines outside of your office. Diabetes, hemoglobin A1C poor control can be a little bit confusing as it's an inverse measure. So for this measure, a lower performance rate is better. And this measure is looking at the percentage of patients ages 18 to 75 with a diagnosis of diabetes who had an hemoglobin A1C greater than 9%, or no documented hemoglobin A1C result during the measurement period. Lab values from an outside source or received as a document need to be added to the EHR in a discrete field associated with the correct low-ink code at the encounter. Faxed or scanned results will not satisfy this measure, and in-house labs should be associated with the correct low-ink code to satisfy this measure. The cervical cancer screening measure is looking for women 24 to 64 years of age who screened for cervical cancer. And again, with this measure, success is really dependent on the low-ink code provided by the lab in the result, and that result does need to be in a value field. So faxed or scanned results will not satisfy this measure, and the screenings must be ordered and resulted and documented in a discrete data field. Breast cancer screening is measuring the percentage of women 50 to 75 years of age with one or more mammograms during the measurement period or the 15 months prior to the measurement period. So a mammogram after October 1st, 2022 for program year 2024. Diagnostic imaging from an outside source or received as a document should be added to the EHR in a discrete data field utilizing proper codes from the value set. Ordering breast cancer screening alone does not satisfy this measure. The screening does have to be completed and resulted in the EHR in order to satisfy the measure. For program year 2024, this measure is going to be looking at patients 18 years or older with a major depression diagnosis, prescribed an antidepressant between April 2023 and April 2024. The continuous treatment described in this measure definition allows for gaps in medication treatment up to a total of 30 days during the 114-day period, which is numerator 1, or 51 days during the 231-day period, which is numerator 2. Gaps can include either gaps used to change medication or treatment gaps to refill the same medication. We really recommend reviewing this measure definition in your current 2023 performance, as this measure does have a lot of nuances. Colorectal cancer screening is measuring the percentage of patients 45 to 75 years of age who had an appropriate screening documented for colorectal cancer screening. Diagnostic imaging or lab results from an outside source or received as a document do need to be added to the EHR in a discrete data field using proper codes from the value set. Again, like with breast cancer screening, ordering the colorectal cancer screening alone does not satisfy the measure. The screening does have to be completed and resulted in order to satisfy measure criteria. So chlamydia screening includes women 16 to 24 years of age who are identified as sexually active and who had a visit during the measurement period. It's important to note that for the purpose of this measure definition, sexually active is defined by codes related to pregnancy, sexually transmitted infections, contraceptives, and infertility treatments. The measure logic will also look to ensure the screening was ordered and that the order returned a result. Low-ink codes may need to be updated with your lab partner so that the correct codes are added to your EHR. So for this measure, weight assessment and counseling, we are looking at 3 different components, and close the gap or state goal needs to be met for all 3 components in order to achieve the full points for this measure. The 3 components include BMI, counseling for nutrition, and counseling for physical activity for patients aged 3 to 17. Counseling must be completed even if the BMI is within the normal range. Be sure to document counseling codes using proper coding contained within the value set and within a discrete data field. Again, free texting does not meet measure criteria. Controlling high blood pressure is looking at patients ages 18 to 85 with a diagnosis of hypertension starting before and continuing into the measurement period or starting during the first 6 months of the measurement period. Patients that are diagnosed with hypertension during the last 6 months of the measurement period will not be included in the denominator. The numerator does require both systolic to be below 140 and diastolic to be below 90. If no blood pressure is recorded, it is assumed that the patient's blood pressure is not controlled. So that is the last measure that is included in your measure options for the Medicaid alternative payment model. I'm happy to take any questions if anybody has questions. You can also email Contexture's quality improvement team at qi@contexture.org, and we're happy to help answer any questions that you might have while you're going through measure selection for program year 2024.
Jillian, we have a couple questions in the chat if you want me to read them out loud.
Sure.
So far. Is the requirement to report both a Medicaid rate and an all patients rate new for 2024? We're a manual reporter, and I don't think we had to separate out the Medicaid rates for 2023.
Yeah, that is a newer requirement. We did start reporting that additional Medicaid-only data set last program year, but it was primarily for our electronic reporters. So reporting that Medicaid-only data set is a newer requirement.
Thank you. Another question, will CPT-2 codes work for A1C reporting?
I'd have to look at the value set. I'm not sure off the top of my head. I don't know if anybody on my team knows off the top of their head if CPT-2 codes work for A1C. It's all dependent on the value set that is set forth by the Value Set Authority Center. So we can check and get back to you on that one.
And Bonnie, yours is similar. It says we push CPT-2 codes with claims for 4 measures: A1C, blood pressure control, depression screening, and advanced care planning. Do these satisfy the measure from an administrative claims-based measure? If not, are they recognized in a CCD document pushed to Contexture? So that will be similar to see if that is in the value set, so it could be counted on the eCQM itself. Another question or comment here, we have Allscripts EHR and we try to get into Allscripts Analytics to pull some reports for manual reporting because our numbers are not correct when pulled by Contexture. Allscripts said we would have to pay a monthly fee to access Allscripts Analytics. So we are asking if Contexture pulls data from Allscripts Analytics if they already have a sign-in. We cannot pay a monthly fee for this, but we need to pull reports to help report correct numbers.
So we do not have a sign-in for Allscripts Analytics. Contexture data is based on the continuity of care documents that are sent to us from your EHR. We don't have access to those EHR dashboards. But we're happy, our team is happy to work with you on that CCD data to improve it so that it's reflecting what you're doing in practice. I know it can be tricky with those value set codes. We need to make sure that number one, that those codes are coming through in the CCD and that you're following the correct workflow. So our team is happy to work with you to try to improve that CCD data. Unfortunately, we don't have control over the vendor fees though.
There's a follow-up comment that they're working with them, but they would need to
Okay.
get a login for Allscripts Analytics. Any additional questions? Jane mentioned, I know that you mentioned this, but can you repeat if all 3 measures must close a gap for the child and adolescent weight assessment and counseling to receive any points?
Yeah, so all 3 parts do have to be met in order to receive full credit for that measure. However, each section of the measure is scored separately. I think each is worth like 11.6667 points. So if you were to meet goal for part A, but not B and C, you would still get more than half credit for that measure because total the measure is worth 35 points. Any other questions? We will send out a copy of the slides after today's call, as well as a recording. I see there's a question. Do we have the ability to see what is being reported on our behalf? Yes, your quality improvement advisor should review the data with you and will ask you to sign off on it that you're comfortable reporting the data. And we do not submit anything unless a practice signs off on it. Anything else? Well, if anyone thinks of anything after the call, feel free to email us, again, qi@contexture.org, and we're happy to answer any questions. We will send out a copy of the slide deck as well as a copy of that recording. And let us know if you need anything. Otherwise, we'll give you all a little time back in your day.